what I'm going to do actually is just give a short presentation which I think highlights some of the restorative aesthetic aspects of implant dentistry, because certainly what I teach on the courses I run, we sort of do an implant day course for restorative. We do our restorative longer courses in just restorative and cosmetic dentistry, and then I teach in Cardiff on the Implant Masters program there. I organise 2 of the modules there, and one of the things that I'm very big on is teaching this restorative aesthetic-led implant planning. And I think this is a nice case to look at, because I'm going to teach it in kind of a conventional way. We're going to look at the role of the CBCT, which is critical. But then rather than digital and scanning, I'll kind of show you almost like a sort of old school way of doing things in terms of a conventional impression technique, and then using the articulator for the case. That said, virtually all of my implant work now is digital, but I think a lot of you don't still have access to digital, and so it's nice just to recap on some of the basics. So it's an interesting case. We can see that we've got this retained deciduous tooth, and really what is the crux and the fundamental of restorative led implant planning is CBCT scan. So what does the CBCT scan allow you to do? Well, there's a number of things it allows you to do, but if you look at bottom right, it enables you to place the implant. So you can do a mock placement, which is fantastic. You can then put a mock abutment on it, and then that superimposes on the current crown. Now, if you haven't got the current crown there, it's easy enough to drop in a wax-up crown into the software as well. And I think that's fantastic, because you can plan what length of implant you want and what width. But look at the width. The width is interesting here. So you can see that we are going for a tapered implant, because if you look about 2/3 down the implant, particularly palatally, the bone comes in a lot. So if you use a parallel-sided implant here, you're going to end up with that implant perforating out potentially of that palatal plate. And then what are you going to do then? Are you just going to leave it? Are you going to raise a flap and put biomaterials and a membrane over it? Also, look, it shows you the soft tissue thickness, the scan. And that's wonderful, because the more soft tissue volume you have, the easier a case it's going to be. And then finally, you can see that we've placed the implant in the ideal position, but look where the abutment is coming through. It's coming through very close to the incisal edge, or on the incisal edge of the crown. So you're looking at this case thinking, right, now this is going to have to be a cement retained option for the patient, or an angle correction screw. What's the other options? You could start going into more complex grafting. You could angle the implant into a more favourable position, but then how are you going to graft over that? I'm not a great fan of using vast amounts of biomaterials like BioOS, BioGuide, these type materials. I don't think that they're as stable as we think long term. So I would rather settle for angle correction here. And this is an interesting case as well, because what are we doing here as well? We are basically doing an immediate extraction and an immediate placement. Because there was very little root on that deciduous element, and we had a reasonable bone volume, we had no infection, we had a good tissue thickness, what we were able to do here was immediately extract, and you can see bottom left with the Straumann range, we have this immediate temporary abutment that we could place. So we placed our immediate temporary abutment. You can see that we've sealed it up with some PTFE, some composite, and now we can place our temporary crown on. And if you remember, this tooth already had a temporary crown on. So what I did was just hollow out that crown, reline it, and actually put the patient's crown back in. But look at the immediate placement and see how it preserves the papillary area and it preserves the buccal architecture of the gingiva. Now, immediate placement is really not for the realms of this presentation today, but do remember, for immediate placement, really you need a case that's easy. You don't want to be doing it in infected cases. You've got to be very careful with your occlusion. I think the patient needs to have a high dental IQ, i.e. they know that this is fragile. They know they've got to eat on the other side. If you've made them a splint, they will wear the splint at night. Now, this was an easy one because the patient was aware of what was going on, but you can see that the patient had retaining wire on the bottom because it was post-orthodontics, and so it enables us to take that crown out of excursions as well. But it's a nice case because it shows what can be done in the right cases with immediate placement and immediate loading of the implant. And then if you look at the temporary abutment, going forward a few weeks, you can see that the buccal plate has been preserved, the papilla has been preserved. You can then take off the temporary abutment, take off the temporary crown, and then you are ready for your restorative phase. And it's nice to show this occasionally. Most of my cases now are done digitally, but on the courses we teach in terms of implants, we still cover conventional impression taking and we cover digital as well, because we're in this transition phase between the two. So we have our implant impression coping, our open tray impression technique, and this is still very simple restorative work. That impression coping will click into the hex on the implant, it screws down, drill a hole in the tray, standard silicone impression with putty wash, and then that is basically your transference of that implant position off to the laboratory. And then, because this is a canine and we've got to be careful with our occlusal forces, you can see that we took a facebow record, and then our crown is going to be constructed on the DENAR to make sure that we can keep a protected occlusion on that crown. And with most of the cases you'll be doing these days, they're often going to be a tie base with a monolithic zirconia crown, which it is in this case. And you can see that the monolithic zirconia, the modern monolithic zirconias, give us a very, very nice cosmetic result. And so if we look at the final result, we can see that we've got a nice implant down on the left, nice bone levels, nice healing after the immediate placement. And you can see that what the zirconia crown gives us is very, very nice aesthetics. It has a real warmth to it, the modern zirconia, nice light reflection properties. It's a nice smooth crown which mimics the teeth either side. But look at what the immediate placement has done for us in this case. We've got preservation of beautiful papillar architecture there, and very, very nice buccal architecture of the gingiva as well. It's a nice screw retained option, so we don't have to worry about cement, we don't have to worry about peri-implantitis. You can see we've got angle correction here, so we've managed to bring that in nicely onto the palatal, and so we've got a nice functional and a nice cosmetic result with this crown here. So thank you very much for your attention today.